Side नहीं जुड़ा अभी, sort है.
Good evening to each and everyone over here. I'm thrilled to welcome you all for today's informative webinar on management of MDR and XDR TB, drug-resistant tuberculosis. I'm Shabnam, manager at Mediversal Academy, and I have the privilege of introducing our esteemed speaker for the evening, Dr. Ayush Pandey. Dr. Ayush is MBBS MD, FCCS USA, FIM, FPC, FNIV Spain, AASC. Dr. Ayush is a consultant physician, diabetologist, and pulmonologist based in Bhopal, currently working at CMCH and Mansarovar Diligent Care Hospitals. He leads the palliative care unit at CMCH and is trained in palliative medicine from the Institute of Palliative Medicine, India. A passionate digital health educator, he has created 500 plus medical videos and built a YouTube community of over 1.5 lakh followers. Dr. Ayush is pursuing the executive program in healthcare management at IIM Shillong and collaborates globally as faculty with the University of Buckingham and as a medical consultant with healthcare firms in the US and India. Thank you so much. Over to you, Dr. Ayush.
Thank you, Shabnam, for the very warm welcome, and it has always been a pleasure conducting sessions with Team Mediversal. So I'm seeing that a lot of good number of participants are there on board, and I expect every participant to have a two-way or a discussion kind of interactive session, so that after the end of this session, I'll make sure that you will have every bit of it regarding the whatever queries you have in mind regarding the MDR or XDR treatment of the tuberculosis, so that will get clear. So I expect everyone, so we'll be discussing a couple of MCQs as we progress ahead. So let's begin the session. So remembering Sir John Crofton, so he's the pioneer in the history of TB control. Why? Because he was the first to study and recognize the importance of drug resistance TB. So he was the initiator of trials which were performed during the early 1950s with the combined regimen for the prevention of drug resistance. Now coming to the first MCQ, and this is again, let us have a brief overview, or let us break the ice by having an overview how much you are aware of it, that MDR TB is defined as resistance to what exactly it is. If I may have the answers in the chat box, that would be, C, isoniazid and rifampicin. Anu is saying. Anyone else? Everyone agrees with C? Are you sure? So what is drug sensitive TB then? C. Okay, let us see the answer. Yes, the answer is exactly right. The answer is multi-drug resistance tuberculosis is resistance to rifampicin along with isoniazid. So it is not just the rifampicin resistance. If we talk about the just drug sensitive TB, then it will be what exactly it is? What exactly is the treatment of drug sensitive TB? Quick, four drugs. So MDR TB is a form of TB which is caused by MTB that are resistant to in vitro to at least isoniazid and rifampicin. So it is isoniazid and rifampicin. This has to be clear. Dr. Nazni, it is not any fluoroquinolones. It is isoniazid and rifampicin. So why INH and rifampicin? Most potent and bactericidal drugs for tuberculosis. TB can be treated effectively with INH and rifampicin alone. But why then we need other drugs? Monoresistance to one of them can be treated effectively with a regimen containing the other agent with a very low failure rate of just 2.5 to 5%. Failure rate if when INH and rifampicin, that is isoniazid and rifampicin, resistance is 40 4% in non-HIV and 70% in HIV. So you see, this is a big number when we talk about if there is a HIV patient, failure rate, if it is a resistance of isoniazid and rifampicin, that is a MDR TB. So failure of regimen can be up to 70%. So duration required for cure doubles to triples. What is XDR then? So it is basically a subset of MDR TB where the bacilli, in addition to INH and rifampicin, that is isoniazid and rifampicin, HNR, are also resistant to any fluoroquinolones and any of these second line injectable drugs like kanamycin, capreomycin, or amikacin. If I have a quick overview, what exactly are the fluoroquinolones we are talking about? Can you name one or two fluoroquinolones which are used in the treatment of tuberculosis, especially MDR? From the audience in the chat box, anyone? Fluoroquinolones. So this exactly is the GLAP. Yes, levofloxacin, Anamika, you are very right. Levoflox, yes. So you see this is a big overview of the picture in which MDR resistance to isoniazid and rifampicin, moxifloxacin. Yes, so levo and moxifloxacins are most commonly used. Dr. Jitendra, you are right. And again, MDR plus resistance to the best second line drugs again can club into a XDR TB. So this whole box of MDR and XDR has been clubbed into a drug resistance TB. So these forms of tuberculosis do not respond to the standard 6 months treatment. So what exactly are the standard 6 months treatment? Quick standard 6 month treatment of a drug sensitive TB, of a normal tuberculosis. With what are the first line anti-TB drugs we are talking about? And these drug resistance TB can be given to 2 years or more, but mostly it is 2 years with drugs that are less effective, more toxic, and more expensive. Drug sensitive TB treatment, anyone from the audience? Isoniazid, rifampicin, 2-HRZE, yes. Ribes, the mnemonic, most common, yes. Rifampicin, isoniazid, pyrazinamide, and ethambutol. You're right, Vijeta. Well done. Good. So WHO estimates that there are almost, 450,000 new MDR TB cases, and more than half of the cases occurred in China, India, and Russia. Endemic? Enrollments on MDR TB in 2012 were equivalent to 1 in 4 MDR cases estimated to occur among pulmonary TB patients which are being notified in the world. So treatment success, 48%, I'm sorry, with MDR TB enrolled on treatment in 2010 were reported to have been successfully treated. Yes, I'm sorry to pronounce your name, but I'll call it Arajo. So it is 2 months of intensive phase followed by 4 months of continuation phase, which you want to mention it, and it is 2 months of HRZE followed by 2 months of HRE. If you talk about the drug sensitive TB. So it is 2 months of rifampicin, isoniazid, pyrazinamide, ethambutol, along with 4 months of HRE. So you exclude Z from the continuation phase in a drug sensitive TB I'm talking, not the drug resistance which we are discussing. So WHO estimates that there are about 650,000 MDR cases in a world at any given point of time. You see how big this number is, 650,000. But only sad to see that out of this 650,000 at any given point of time, only a small proportion of these cases are detected, treated appropriately, especially in low and middle income countries, because still there is a big challenge to the diagnostic capacity to treat MDR TB. Now coming to the another MCQ, let's break it. First test to diagnose MDR TB. If you talk about in India, chest X-ray, LPA, CBNAT, and culture and DST. Can we have the answer from the audience? Quick. X-ray, Dr. Vijeta is saying, are you sure X-ray? Because X-ray will give you a differential diagnosis, I can say. But to diagnose it and to give a confirmatory, you need some microbiological tests to rule out. So yes, Dr. LU, you are right. It is the CBNAT, the first test, because until and unless you get a CBNAT resistance, you do a AFB, you send a sputum culture. So sputum, what are the findings you will see? So in sputum, you will see a AFB, and then you will run a CBNAT, which is the cartridge-based nucleic acid amplification test. Dr. Vishal, you are right. Again, Dr. Arajo, you are also right. So in CBNAT, you will see whether it is a rifampicin resistance or a rifampicin sensitivity. sensitive. So that exactly the comes. So if it is a rifampicin sensitive, it is a drug sensitive TB until unless there is no resistance detected. Now coming to this, RRTB refers to resistance, which we have discussed this. Resistance to RRTB refers to resistance to rifampicin with or without resistance. So what exactly is the answer? Yes, rifampicin with or without resistance to other drug. Exactly, you're right, Dr. Farhana, Dr. Nazneen. It is the RRTB. RR from the name only it suggests that rifampicin resistance. So it has to be rifampicin resistance, na? So RRTB is rifampicin with or without resistance. It can't be exactly, just the rifampicin. It is exclusively, but again, it is not solely. So now global prevalence of this is 3.4% in new TB patients, talking about MDR TB, and 20% in those who are previously treated. So by October 2011, so these are the data, these are continuously being revised over a period of time. When we talk about these data, these are almost 15 years, but over the time, this data has been revised. So 77%, 77 countries has reported at least one cases of XDR, especially in, African continent because of a low capacity for testing. Also in India. So WHO estimate that 5% of the people with MDR may have actually XDR also. So you see this. This is the data 2011. So 2011 to 2025, almost you see there has been a gap of 14 to 15 years, and it is almost fan spread. When you talk about the coverage and you see of India, it is almost everything in red except the portion of Jammu and Kashmir, because maybe of fresh air or so, but mostly it is because of the environmental. There are a lot of factors, but yes, you see these data are 15 years old. So you talk about the burden of the population. If you talk about 8.6 million estimated TB cases, and then you have 77,000 MDR TB cases diagnosed and on treatment, 450,000 estimated new cases, XDR 45,000, 10% estimated cases of XDR, and 5.7 million new cases which are being diagnosed and treated. So this whole, if you call it as a, especially in math, we call it as a Venn diagram. So you see this within the circle and circle, how big this number is, 8.6 million if we talk about. Again, estimated number of MDR cases greater than 60% of all cases are in majority of the 6 countries. And these 6 countries are Russia, South Africa, Pakistan, India, Philippines. Till after 15 years, this data has definitely been, some countries has been added up. But when talking about India, Africa, Pakistan, they are still there and they form the majority of the burden population. So why you think that this emergence is there? What can you think that what exactly is the cause of this emergence? Ineffective TB regimens? Yes. Any quack, anyone is giving, and this levofloxacin, even in the chat box, you have said that fluoroquinolones, these are being used as so, like a dhadalla kind of thing. They are being used at each and every corner of the city, at each and every corner of the state. Even for treating the normal bacterial infection, fluoroquinolones are being used, and they are being, overused. Delayed diagnosis, yes. What exactly is this? Wrong dose. So still till date, people are not clear about the treatment of what they are treating. It is like TB, give HRZD. Especially talking about India, if you talk about that government sample or government drug which is being there, we call it in this, layman terms that lal patta de do. For because that intensive phase which is being there of the drug sensitive TB, that comes in 2 color, intensive and continuation. So intensive phase color is of red color and continuation phase color is of green color. So every quack or every, even the most of the clinicians who are being, well educated or so, talking about the specific treatment. Yes, non-compliance, Sanoj, you're right. Non-compliance is the next option, which I was coming to. Non-compliance, because you know what happens if you put the patient on TB, whether it is a drug sensitive or drug resistance, after the symptomatic improvement, maybe the symptomatic improvement do occur. You believe? Yes, it do occurs. In fact, in a couple of weeks only, the patient will feel good. because all the coughing, if it is a pulmonary TB, coughing, shortness of breath, fever. So over a period of time, this will get settled, especially after 2 weeks. So then what happens? The patient becomes reluctant. Ki, I'll take treatment for 6 months. If you talk about drug sensitive and if you talk about drug resistance also, even in new treatment, which we'll be discussing what are the regimens which are there in the market, even the duration of the treatment has been fallen down to even a year or maybe to less than a year. People are still reluctant. People are not taking. Wrong duration of treatment. What exactly is the dose? What exactly is the duration? They exactly are not aware of. And even the clinicians, I'm very sad to say, majority of the trained clinicians, not majority, but yes, a big number of them, they are not exactly telling what exactly is the duration should be. Poor quality of drugs, especially there is a lot of, I'll say that there is a lot of, even the government supply of the medications is there, and the government has strictly told the patients also to be compliant to the government medications. But even after that, there is a, black marketing of these drugs. And because of that black marketing, majority of the big company and big players are there. And even the small companies, small pharmaceutical companies have come into play. And because of that, they are compromising on the quality. Contact with a drug resistant TB patient. Yes, and comorbidities, especially HIV positive, which we discussed in the previous slide. So MDR TB is a mandate problem. It is a costly, deadly, and biggest threat to control our TB current control regimen. Now coming to the another MCQ, which of the following is not a risk factor for MDR TB? What exactly you think? Previous TB, HIV TB, contact with the MDR, or first ever diagnosis of a TB in a asymptomatic? Quick. Because I'll say until and unless you don't participate in this session, just having the participating just for the certificate, because I'll tell you after this session your all the concept for this MDR and XDR treatment will change, and definitely it will help you a lot in your clinical practice. Yes, D is the right answer. First ever contact. A primary MDR in a asymptomatic person is not 100%. It is not, it can't occur. It can occur, but the chances are very, very less. So previous TB, HIV, TB, and a contact with a known MDR still holds a true risk factor. Yes, the most important risk factor for the development of drug resistance is previous treatment. What exactly is the previous treatment they have taken? You see that majority of you have told also in the comment box that non-compliance is one, majority of the risk factor that patient have landed from a drug sensitive to a drug resistance. Now, what exactly is this primary or pre-treatment resistance? So one drug resistance is demonstrated in a patient who has never received anti-TB treatment previously. It is a primary resistance. But again, when the bacteria were sensitive to the drug at the start of the treatment, but became resistant to the particular drug during the course of the treatment. You see this? Even during the course of the treatment, it is a acquired or a secondary resistance. Now, what exactly is this pre-XDR TB is defined as? MDR plus resistance to group A, MDR plus resistance to any fluoroquinolones, MDR plus resistance to aminoglycosides, or MDR resistance to rifampicin alone. Because this concept has to be very clear. What exactly are we discussing in this session? Until unless you are not clear with the concept, it is very difficult to understand what we are being talking about, and it becomes difficult also what you will treat. B, and yes, the answer is right. The B is the right answer. MDR RR-TB plus resistance to any fluoroquinolones, as we see that it is being, most again a drug which has been most commonly used. So microbial, again, acquired drug resistance is caused by spontaneous mutations in chromosomal genes, the selection of resistance strain during the suboptimal drug therapy. And again, if you talk about the clinical, due to inadequate treatment. So what exactly is the mechanism of drug resistance? And if you go for any competitive exams, if you are even in your course of your post graduation or also in your undergraduation course, this is the one of the most common questions, also most commonly asked in the viva. What exactly is the mechanism of drug resistance of TB? So TB bacilli has, natural defenses against the drug and can acquire drug resistance through the genetic mutations. And the mechanism include: the first is cell wall. The cell wall of Mycobacterium tuberculosis contains lipid molecules which act as a barrier to stop the drugs from entering the cell. And that's why we need the bactericidal drugs. Yes. drug modifying and inactivating enzymes. The TB genome codes for enzymes, protein that inactivate the drug molecules, and these enzymes usually are phosphorylate, acetylate, or adenylate drug compounds. Drug efflux systems, the TB cells contain molecular systems that actively pump drug molecules out of these cells, and mutations in the TB genome that can alter the protein which are the target of the drugs, making the resistance of the bacteria. So specific, if we talk about the drug and the mechanism, what exactly are the mechanisms? Isoniazid, inhibition of mycolic acid biosynthesis, component of cell wall. Mutations in CAT, G, INHA, and AHPC mutation is there of the genes. If we talk about rifampicin, inhibition of transcription, mutation of the RPOB gene, prevent interaction with rifampicin. Streptomycin, inhibition of protein synthesis, mutation, prevent interaction with streptokinase resistance. Ethambutol, inhibition of arabinogalactan and lipoarabinogalactan biosynthesis. Overexpression or mutation of EMBB allow continuous arabinan biosynthesis. Fluoroquinolones, inhibition of DNA gyrase. Pyrazinamide, yet again to find out, and mutation in GYRA prevent interaction with fluoroquinolones. So these are the various, antimicrobial agent, the mechanism of action and the mechanism of resistance which they develop. So if we club this, isoniazid, CAT, G, INHA, rifampicin, RPOB, and these are, again the favorite Viva questions, or you talk about the theoretical questions. These are again the common. Ethambutol, EMBB. So what are the causes of inadequate treatment? We have discussed this, but again, the absence of inappropriate guidelines. Thanks to the, Ministry of Family and Health Welfare and Ministry of TB, India, they come out with the guidelines every year. And with every year of these guidelines, if you want to download the MDR TB guidelines or the drug sensitive TB guidelines, you can go to the Ministry of TB site. You can click there on the Google also, and you can they have a specific guidelines that contains a PDF, very beautiful chart with all the flow charts they have explained how to, treat whether a drug sensitive or a drug resistance TB. So every year they come up with, these guidelines, and every year there is a modification of that guidelines. So non-compliance with the guidelines, yes, inadequate training of the health staff, no monitoring, poorly organized, funded TB control programs yet there, because earlier it was, RNTCP program, revised National Tuberculosis Control Program, and now what is it has been changed to? If I may have someone from the audience, the RNTCP program, now the government has given it a new name. What exactly? Now it is again 2-3 years has been passed. That name has been given, but what exactly is the guidelines? NTEP, yes, Dr. Shreyans, that is the National Tuberculosis Elimination Program. So our beloved Prime Minister, he told that, with the NTEP program, it was told that we have to eliminate TB by 2025. But again, this is not possible because 2025 is about to end. And this program will get extended as per the news is coming for at least 5 years. And even after 5 years, this will get extended. So do you think that we'll be able to eliminate TB? Are anyone from the audience? Do you think that we'll be able to eliminate? Dr. Neelbani is saying yes. Vijeta is saying no. Until and unless we are there on the earth, I don't think TB will be eliminated. Because of the, it is very difficult to, because this drug resistance case are on the rise. Now, this drug, even when we talked about now primary MDR, these cases are definitely getting reduced. But again, this drug resistance cases are on the rise. So because of that drug resistance case, it is becoming difficult to treat, because although we have come up with guidelines, and which we'll be discussing in the further sessions, what exactly, because of this drug resistance, it is becoming a very challenging task. Government is definitely, coming up with all the guidelines, coming up with all the drugs. But again, availability of drugs, storage conditions, social economic barriers, adverse drug reactions, there are a lot of inadequate treatment causes. So like all the forms of drug resistance, tuberculosis, TB is human made. Yes, MDR TB can be amplified into XDR TB by inadequate interrupted treatment, indiscriminate use of second line drugs, non-adherence to the guidelines, increased use of fluoroquinolones in combination with first line, and weak systems to ensure standardized treatment and treatment adherence. Now coming to this, which was the revised definition, XDR TB is, according to the WHO India definition, MDR plus resistance to second line injectable, MDR plus resistance to all fluoroquinolones, MDR plus resistance to any fluoroquinolones, or plus at least one group A drug, that is the BDQ and LZD, that is the bedaquiline and linezolid. Dr. Anamika is saying C, Priya is saying C, Dr. Jitendra is saying C, so I will also go with C only. Yes, the answer is C. It is resistance to any fluoroquinolones plus at least one group A drug. Many failures are due to failure to take the treatment and not failure of the treatment. Yes. So impact of drug resistance, prolonged illness, increase in the mortality, increase in the cost, direct, indirect, and prolonged period of infectiousness with increased risk of transmission. MDR suspect TB criteria. So these are the criteria. All failure of new TB cases, smear positive, previously treated, who remains smear positive even after 4 months. So you have started a patient on a drug sensitive. So especially we hope that at the end of 2 months, at the end of intensive phase, this gets, although smear conversion generally occur after a period of 2 weeks, mostly after 1 month. But at the end of 4 months, you definitely expect that AFB becomes negative. But at least you continue the treatment for 6 months of drug sensitive TB. But again, even if there is a positive after 4 months, something should ring in your bell that why this smear is getting positive even after 4 months. I have given 2 months of intensive phase. I have given 2 months of continuation phase. Then something should ring bell, and it should, it should allow you to think whether it can be a MDR TB also. So all pulmonary TB cases with the contact of MDR, criteria B, in addition to the criteria A, smear positive plus previous treated pulmonary TB, smear positive follow-up in new or previously treated cases, and criteria C, in addition to B, all smear negative previously treated pulmonary TB cases at diagnosis, and HIV TB. Yes, HIV TB is a deadly combo. So 3 technologies for the diagnosis. The first is the egg-based culture media, that is the Loesten-Jensen media, MJIT. We call it as a mycobacterial growth indicator tube. And the third is the line probe assay, nucleic acid amplification test like the Gene Expert or CBNAT. So yes, MDR diagnostic technology, molecular DST, that is the LPA DST first, liquid culture isolation and LPA DST second, solid culture isolation and LPA DST third. Fourth is the liquid culture isolation and the liquid DST, and the fifth is the solid cultural isolation and DST. Now talking about the line probe assay. So detects RPOB mutations, rapid processing because it has a turnover time of less than 48 hours, and detects drug susceptibility to the second line agents. Now coming to this, line probe assay is based on which principle? Culture, antigen, antibody, ELISA or PCR? What exactly you think? Line probe assay? LPA, the short form, and very commonly you see if you have been working or if you have been, especially everyone must have, be there in the medical school. So especially we say that send LPA, bhej do uska LPA. So what is this LPA which is based on? Jason is saying antigen antibody. A, okay, Roop Jyoti is saying ASKC. So the answer is A. It is a PCR amplification, and because of that PCR amplification, the turnover time of this is less. So it is a PCR amplification and reverse hybridization. So this is the line probe assay for the MDR TB plus and C. So you see this for the first line drugs and for the second line drugs, which is being done. So first line LPA. Now there are, if you must be aware of, there are 2 types of LPA, the first line and the second line. So first line LPA is primarily used for detection to resistance to what? What do you think? Isoniazid, rifampicin, only fluoroquinolones, aminoglycosides, or pyrazinamide, ethambutol. A, majority of them are saying A. Okay. So I'll also go with A only. It is isoniazid and rifampicin, the first line LPA. So you see this, your heads or, consultant must be selling that send the first line LPA. Why? For the detection of isoniazid and rifampicin, if you get a rifampicin resistance, it is mandatory, then you send a first line LPA. So you see for the detection of rifampicin resistance, you see the sensitivity and the specificity, 97 and 99. And we talk about when we combine for the isoniazid and rifampicin, sensitivity is again on the higher side, 90 and 99%. So second line LPA. Now, first line was for isoniazid and rifampicin. Second line LPA, then what is the role of this second line LPA? For what it is sent? Rifampicin, isoniazid only, fluoroquinolones and second line injectable, pyrazinamide only, or pretominid or bedaquiline, sorry. Neelmani is saying B, Rupjyoti B. Majority of them are saying B. Okay, I'll also go with B only. Yes, the second line is for fluoroquinolones and second line injectable. So you should have a clear overview. What are you sending? Whether it is a first line LPA for isoniazid and rifampicin, a second line LPA for fluoroquinolones and second line injectable drugs. Now, this gene expert, as we have talked about, nucleic acid amplification test, purifies, concentrates, amplifies, and the turnover time is almost around 50 to 55 minutes. So this is 90 minutes. But again, with the new, we have come with a new machine of CBNet Ultra. So with every, new machines, the turnover time of this detection has become less. So you see this smear positive, 98.2%, smear negative, still on the higher side. Yeah. So even if we get as AFB negative, you again send a CBNet. Na? If you're suspecting a TB, if you have clinical correlation, X-ray, CT correlating, you don't stick to the AFB only. Why? Because even in smear negative cases, 72.5% sensitivity is there of gene expert and specificity is 99. When talking about the rifampicin resistance detection, yes, 98, 99, you see a big good number. And that's why we send a CBNet. Liquid culture, MGIT, detects reduction in oxygen concentration because Mycobacteria is a oxygen-loving bacteria, aerobic. Fluorescence with low oxygen is seen, and average time to positive is somewhere between 4 to 14 days. Reverse line blot hybridization, that is RLBH, in-house assay that could rapidly detect resistance to drug involved in the definition of XDR TB directly from smear positive specimens. The results are as accurate as other drug susceptibility, and testing takes only 3 days to determine how resistant the strain of the bacteria was. Now, DNRA, direct nitrate reductase. So, it has shown efficient accuracy for the rapidly and simultaneously detection of resistance to isoniazid, rifampicin, kanamycin, and ofloxacin, that is the fluoroquinolones. DNRA results are obtained in 16.9 days, comparatively less than the other drug susceptibility testing. At the same time, the DNRA is a low-cost technology, easy to set up in clinical laboratories and suitable to prevent use for DST in all smear positive cases. So this was the study which was done, direct nitrate reductase test, and what they found out. So based on this study, results were compared with the MGIT. And the general performance of this DNRA test was very good, reaching a global value of 97% and a turnaround time of 16.9 days to obtain the results, while that of indirect MGIT was 29 days. So this is a low-cost technology, easy to set up in clinical laboratories and suitable to be used for DST of MTB in small or smear positive. So talking about the statistical parameters which was being observed to different drugs when talking about this study. So newer, cheap and effective approach in TB diagnosis is the MODS, that is the microscopic observation drug sensitivity assay. And the advantage of this is it requires a minimal staff training, cheaper, faster compared to the liquid culture based test, can be implemented on a large scale very rapidly as compared to the very costly equipments used for LP or NET. So baseline assessment in MDR TB includes all except HIV, sputum, chest and liver biopsy. Quick to the answer. Come on from the audience. D, majority of them are saying D. Sure. Yes, D, liver biopsy. Generally no role for this MDR RR. You send a sputum, you do X-ray, you do HIV for the HIV TB combo, and then yes, liver. So since the drugs used for the MDR are known to produce adverse effect, a pre-treatment evaluation is very much important at increased risk of developing this adverse effect. And what are these pre-treatment evaluation? You need to have this checklist. So you need to have, starting with the detailed history, along with the weight, height of the patient. You send a complete CBC profile with the platelet count, blood sugar, LFT, KFT, along with the, TSH levels, thyroid profile, urine examination, pregnancy test, very much important if the female is pregnant, and a chest X-ray. So these are the pre-checklist. Now talking about the anti-tuberculosis drug, which are there, and these are the latest treatment and the latest group. Earlier we used to have CAT 1, 2, 3, 4 category. Everything has been wiped off, and now everything which we are left with these three groups. That is the group A, which contains levofloxacin, moxifloxacin, bedaquiline, linezolid. Group B, clofazimine, cycloserine, or terizidone. Ethambutol in the group C, delaminate, pyrazinamide, imipenem or meropenem, amikacin, streptomycin, ethionamide, prothionamide, or PAS. That is the para-amino salicylic acid. So you can have a screenshot, or you can take a picture. All we are left with is the three category of these drugs. Now talking about the B-PALM regimen, which is the first regimen for the treatment of MDR TB. And if you talk about the latest guidelines of the NTEP, which has come this year, you can go and check on the internet also. They have given the three categories for the treatment of MDR, three regimen for the treatment. The first is the B-PALM regimen. So this must be the first choice of treatment in all the eligible patients greater than 14 years with MDR TB, regardless of their fluoroquinolone resistance status or HIV status. So they have some inclusion criteria and exclusion criteria also. The first is the age, definitely, which I talk about, with a new microbiologically confirmed MDR requiring a new course of treatment, who have failed a H mono or poly-DR TB regimen, or person with exposure of more than 1 month intake of bedaquiline, linezolid, and or pretomanid, or patient who have not failed containing shorter or oral regimen and sensitive to these drugs. If the QTC prolongation is ECG is less than equal to 450 in males and females, serum electrolytes abnormal and QTC again greater. After correcting the electrolytes, the QTC again less than 450 and less than 470 in females. Non-lactating women, but they should not be breastfeeding, non-pregnant, pregnant women if present less than 20 or less than 24 weeks, and who is billing for MTP according to the MTP guidelines. What are the exclusion criteria? Yes, less than 14 years. Patient with liver dysfunction, resistance to bedaquiline, linezolid, or pretomanid, with severe forms of extrapulmonary TB, like if there is a spinal TB, meningeal TB, disseminated TB, with significant cardiac abnormalities. Patient currently having uncontrolled cardiac arrhythmia, torsades de pointis, and all the QTC prolongation greater than 450 in males. Again, so if 470 in females, so these are the exclusion criteria for the B-PALM regimen, which is the first regimen. So the first is the bedaquiline, and what exactly the bedaquiline, for how much you will give. So bedaquiline for 1 to 2 weeks is given 400 mg once a daily. From the third week to the 26 to 39, the dose becomes 200 mg thrice a week. Along with bedaquiline, you give pretonomid for week 1 to 26 to 39, 200 mg daily. So bedaquiline was 200 mg thrice a week after 400 mg day. After 400 mg once a day. And pretonomid is 200 mg OD. Talking about the linezolid, from week 1 to 26 to 39, it is 600 mg once a daily, along with moxifloxacin. From week 1 to 26 to 29, it is 400 mg once a day. Pyridoxine, to prevent neural complications, it is given according to the body weight. So the body weight is between 16 to 29, you give 50, greater than equal to 30, you give 100. So these are the B-PALM regimen along with the pyridoxine you give. So this is the comparison of bedaquiline, linezolid, moxifloxacin, which has to be given. So WHO recommends, again, this oral bedaquiline containing regimens are preferred over the longer 18 greater than equal to 18 months regimen in adults and children without previous exposure to second line treatment, without fluoroquinolone resistance, with no extensive pulmonary disease or severe EPTB. Now coming to the MCQ, which drug is not a part of B-PALM regimen? We have discussed in the previous slide. We have discussed the B-PALM regimen. We have discussed the dose and the duration. What is then which drug we haven't discussed? Yes, you are right. Kanamycin is not. So as by the name only, B palm, B for bedaquiline, P for pitonamide, and L for linezolid, and M for moxifloxacin. So B palm, kanamycin is not there. Now talking about the shorter oral MDR or RR-TB regimen for adults. Standard treatment of the regimen, if you see, it has come down to 8 drugs. Isoniazid, ethionamide, pyrazinamide, ethambutol, clofazimine, pyridoxine, levofloxacin, and bedaquiline. So you start with the intensive phase of 2 months, maybe of linezolid, 4 to 6 months of if 4 to 6 months of levofloxacin, clofazimine, pyrazinamide, ethambutol, or high. What is this HH? Can anyone say what is this HH? Why I have written this HH? Or it is a mistake, typing mistake. Can anyone say? We give isoniazid in a normal dose or some other dose if we talk about this shorter oral MDR regimen. Yes, it is higher. It is high dose isoniazid. That's why very good, Neil Mani. It is H, a small h is for a high dose isoniazid which we give. Which we don't give a normal dose of isoniazid, which we give in a dose of 5 mg per kg body weight. So again, coming back to this, we can, 2 months linezolid, 4 to 6 months levofloxacin, clofazimine, pyridoxine, ethambutol, high dose isoniazid with 6 to 9 months of bedaquiline and 5 months of levofloxacin, clofazimine, pyrazinamide, ethambutol, or you give a 4 to 6 months of levofloxacin, clofazimine, ethionamide, pyrazinamide, ethambutol, high dose isoniazid with 6 to 9 months of bedaquiline along with 5 months of levofloxacin, clofazimine, pyrazinamide, and ethambutol. So these are again the various drugs, and these drugs are given according to the body weight. You see this? If the weight is between 16 to 29, that H which I was talking about, which is the higher dose, Dr. Nazni, you are right. So higher dose of isoniazid and each and every drugs which we have discussed, they are given according to the body weight. 16 to 29, 30 to 45, 46 to 70, and greater than 70. So with the kg, with the weight, the dose of the, all the drugs which are there, which I have discussed, all the 8 drugs, high dose isoniazid, ethambutol, pyrazinamide, levofloxacin, bedaquiline, clofazimine, ethionamide, and pyridoxine. But very importantly, if you see the dose of bedaquiline, 0 to 2 weeks, 400 mg OD, from 3 to 24 weeks, 200 mg thrice a week. So this concept has to be very clear in your mind. Now talking, if you are clear with the concept of shorter all oral MDR TB regimen, how much duration this MDR TB regimen all oral longer is there? Whether it is a 12, 24, 6. NIDA, we are not discussing a drug sensitive. Are you sure this is a 6 month? Majority of them are saying 6 months. Lord, you have said swastik B. Yes. So I'll go with B. It is 9 to 11 months. It is not 6 months. The 6 months was B palm regimen, which you have discussed. Any doubt you can ask in the chat box. I'll take the questions at the end. This B palm regimen was for 6 months, but this shorter oral MDR TB regimen is minimum of 9 to 11 months. Why? Because you come to back to this slide, you look at the bottom portion of this slide, what is there in the bracket? That 2, that 6 to 9, and the second box you see that 5. So if you club this 4 to 6 plus 5, the first box and the second box, how much the total is coming? It is 11 months. Now coming back to the second box, if you see 4 to 6 and going back to the second box, 6 plus 5, again it is 11 months. So the treatment is 9 to 11 months. You have to be, very clear with the concept for how long we are giving this treatment. I hope I am clear. The answer is 9 to 11 months. Now, there are some eligibility criteria for this shorter oral. Why? Because we start with the B palm. But again, what are the eligibility criteria when we talk about this shorter oral MDR? So rifampicin resistance has to be detected. Yes. With fluoroquinolone resistance, it should not be detected. Why? Because we are giving levofloxacin in this. No extensive TB disease, no extensive extrapulmonary. Again, INH mutation and CATG mutation. They have the specific criteria. Non-lactating woman, not pregnant, but if there is a pregnant woman, less than 20 and less than 24 weeks, but again, willing to go for MTP. So more or less, if you see this eligibility criteria is being fitting with the B-Palm regimen, which we have discussed. Now coming to the longer oral MDR. So if we have a short, we'll have a long also. So you see this, what are the drugs which are being given in this longer oral bedaquiline in the MDR or XDR TB? So you see there is levofloxacin, moxifloxacin, high dose moxifloxacin, bedaquiline in the same dose which we have been discussing in the previous two regimen, clofazimine, cycloserine, linezolid, delaminate, amikacin, pyrazinamide, ethionamide, PAS, ethambutol, imipenem, meropenem, amoxicillin, and pyridoxine. Again, these all drugs are being given how? According to the body weight. And with the increase in the body weight or change in the body weight, the dose of this medication changes. So now, if you are being, switching from a shorter to longer, when it is being required, when do you think why you require a longer regimen if you have a shorter regimen? Why you need to give, there are definitely a lot of more drugs when we talk about, 6 longer are there, bedaquiline, then you have a levofloxacin, linezolid. So why you require a switch if you have a shorter? Why do you think? Patient gains weight, are you sure? Patient gains weight is the criteria. Patient becomes smear negative, resistance to fluoroquinolones. Yes. Why? Why exactly is this so? Because in the shorter regimen, what exactly was we given? We were given fluoroquinolones. If you see, we are giving fluoroquinolones here also, but we are giving in a dose which are different than the dose which we have detected. So there is the resistance to the fluoroquinolones. If it has been detected, it is better. You have to then maybe switch from shorter to a longer regimen. So longer now, if we have a shorter treatment for 9 to 11 months, what exactly you think the longer MDR or XDR regimen duration is? Is it the same? DC, DC, DC. Many of them are saying DC, DC, DC. Dr. Labesh is saying C, Dr. Jiten, Dr. Shreyan C. So I'll also go with C only. It is 18 to 20 months. Somewhere between 1.5, close to 2 years. But again, this can also be extended. But again, if you talk about the standard regime or the standard treatment of duration, according to the latest NTP guidelines, it is 18 to 20 months. In the shorter, it was 9 to 11 months. Now, this is a very beautiful chart. If you understand this chart, your concept of the treatment of a resistance case of TB is confirmed. So if you have all notified TB patients which are not offered a RR, that is a rifampicin resistant TB test, all presumptive TB test, or a non-responder to any regimen, what you will do, you will collect the specimen and you will test the resistance for isoniazid, rifampicin, fluoroquinolones. Again, if you have a MTB detected, MTB positive, rifampicin resistance detected, what exactly you will do? You have to have clear with this understanding. You collect this specimen, you send the resistance. I'm talking about the green box if you are not able to correlate with this flow chart. So after you switch from the green box, if you have an MTB positive rifampicin resistance detected, whether it is a less than 14 or a greater than 14. Greater than 14, eligible for B-Palm according to the eligibility criteria, give a B-Palm dose. Again, less than 14 years, no, if the eligibility of B-Palm is not there, you give a shorter oral regimen, 9 to 11 months. Again, if that is also not possible, what you will do, you give a longer oral regimen. You see this? A no comes to the longer oral. Again, if the shorter oral regimen is possible, you give a shorter oral regimen. Again, if B-Palm, you check for additional resistance, intolerance, non-availability of the other drug, emergence of exclusion criteria. And again, you may switch to longer oral regimen accordingly. But this is the standard protocol if it is a MTB positive or resistance detected. Now coming to the right side of the differentiation of the green box, that is the MTB positive. If you don't get a rifampicin resistance, so if you are a rifampicin sensitive, you will give a drug sensitive treatment, that is the 2 months of HRZE along with a 4 month of HRE. But along with that, you test for isoniazid resistance. So if isoniazid resistance is detected, you give 6 to 9 months of levofloxacin along with rifampicin, pyrazinamide, and ethambutol. additional resistance or intolerance or non-availability of any drug in use, you switch to isoniazid mono or poly drug resistance TB regimen and modify accordingly. So still, if you clinically correlate test for resistance for rifampicin resistance detected, switch back to the MDR TB regimen. Not detected, again, it can be a probable MDR. Again, if the person is improving with this 6 to 9 months of, levofloxacin or a H monopoly regimen, complete the treatment. Again, if S resistance is not detected, if you don't get R resistance, complete the course of this drug sensitive TB. So this is a very beautiful flow chart. If you understand this, you can take a picture of it. You can have this for your reference. You have to be clear. So now clubbing the three regimens which we have, the B palm 6 months, when you will give MDR RR-TB pre-XDR age greater than 40 years, resistance to bedaquiline or no resistance to bedaquiline, pretonamide, linezolid or moxifloxacin. Shorter oral 9 to 11 months, longer oral 18 to 20. Shorter oral MDR RR, no fluoroquinolones resistance, age greater than 6, and longer oral pre-XDR not eligible for B palm or a shorter regimen or a resistance to a fluoroquinolone. So this is very clear. Now you see this chart and I'll ask you a question with this chart, why I've given this chart, the regimen, and there are some injectables if you talk about, kanamycin especially. Again, it is oral also, but again, so use of injectables like amikacin, kanamycin in MDR XDR TB regimen. If we talk about the latest current guidelines, what do you think will be the option? Anyone from the audience? First line mandatory, optional if or oral drugs available, not preferred, replaced by oral. Neil Mani, yes. Given to all oral pre-XDR. So what exactly is the answer? Majority of you are right. It is not preferred. Majority of the injectables have been replaced by all oral regimens and they are not preferred. So how you will follow up with this case? So patient of MDR cases admitted, evaluated and treatment initiation has been done. You can discharge if the patient is stable and you can again refer the patient back to the DTO, daily DOTS continuation provided by a DOTS provider, and follow protocol has to be done by the smear culture, monthly during the IP, quarterly during the CP, physical evaluation along with the KFT and other investigations have to be done. So how you will follow up with smear and culture? 2 specimens for AFB, one early morning and one spot sample has to be collected at the end of each month of treatment. If we talk about the longer, 2 specimens for culture are also collected and sent to the DTC. And again, if any of the culture in the last 3 quarters become positive, it will be followed up by monthly cultures in the following 3 months. So after 6 months of treatment in the intensive phase, patient will be reviewed and the treatment change to the CP if the 4th month culture result is negative. If the result of 4th month culture is still awaited after 6 months of treatment, IP is extended until the result is available. IP can be extended to 3 months from 2 months after the patient will be initiated on the CP, irrespective of the culture results. So what exactly is the definition? If you talk about the cure of a MDR TB patient, he has completed the treatment and has been consistent culture negative with at least 5 consecutive negative results in the 12 to 15 months if we talk about a longer oral regimen. But again, there has to be 5 culture which has to be negative, and treatment completed who has completed the treatment according to the guidelines but not meet the definition for cure or treatment failure due to the lack of bacteriological results. Now, these are the various diagnostic modalities you'll see. And again, this is one of the important slide. Again, I will tell you to keep maybe a note of it. CBNAT, what it will detect? It will detect TB and rifampicin resistance. R sensitive, switch, give a drug sensitive. R resistance, send a LPA, which we have discussed, the first line LPA and the second line LPA. First line LPA, I and R, that is the isoniazid and rifampicin. Second line LPA, what exactly it will detect? A fluoroquinolone resistance. The third is the culture, that is the MGT and solid culture. growth-based drug susceptibility for the first and second line drugs, confirm resistance when the molecular results which are being done above are inconclusive. Now again, we have some advanced molecular tests which are being there. And when there is a comprehensive resistance to the all profiles, when you get an extreme drug resistance in whether maybe you plan a research study, you plan a trial, then there are some advanced research, molecular tests which are being available. So along with the baseline monitoring, which you do for HIV, LFT, KFT, everything which are there. Now, which investigation is to be done monthly? If we talk about in a TB follow-up case, we have discussed what exactly we need. What exactly we need on a monthly basis if we talk about the treatment for a follow-up. BBB, majority of yes. I'll go with the B, smear culture, sputum culture. You need a B sputum culture. You need to have minimum 5 as we have discussed. So you need to have this sputum culture negative. So what exactly is the role of now surgery? We have discussed this, treatment modality regimen. So in MDR TB patients with localized disease, surgery as an adjunct to chemotherapy can improve the outcome. So if there is, if you need maybe a lobectomy, pneumonectomy, if the whole of the lung parenchyma or if whole of the organ can be resected. So when unilateral resectable disease is present, surgery should be considered for the following cases. Absence of clinical or bacteriological response to chemotherapy despite 6 to 9 months of treatment with effective anti-TB drugs, high risk of failure or relapse due to high degree of resistance or extensive parenchymal involvement. Morbid conditions of parenchymal disease, you have a bronchiectasis, bronchopleural fistula, pus in the pleural cavity, that is the empyema, recurrence of positive culture status during the course of treatment, relapse after completion of anti-TB, and if surgical option is under consideration, at least 6 to 9 months of chemotherapy is recommended prior to surgery. Chemotherapy, we are talking about the drugs, the anti-TB drugs, which we are talking about, not the anti-cancerous drug. So what exactly you think is the treatment success rate in India if we talk about this cohort of this MDR TB? What do you think? What exactly is the treatment success with all we have discussed, with the failure rate, with the compliance, with the treatment modalities, the challenges, what exactly you think can be the treatment? A, 40%. So you are playing somewhere between 50-50. Okay. So exactly this is, more beyond that, it is 75%. So if the compliance is being followed, if it is being done, the 75% treatment success rate is definitely there. Now, the management of MDR and XDR in special situations. If the woman is a pregnant female, whether she is a less than 24 week, less than 20, or a greater than that, if she is a less than 20, less than 24, advise MTP. MTP done. Start the patient or the female or B-palm regimen or a shorter oral MDR RR regimen or longer oral MDR XDR TB regimen according to the inclusion or exclusion criteria that fits in. But again, there can be a challenge that the female doesn't want to terminate her pregnancy. So if she is unwilling and if she is a greater than 20-24 weeker, can start on the 9-month shorter oral MDR RR regimen with linezolid or a longer oral MDR XDR TB regimen. Now, MDR TB deadly combo is more common in HIV patients. Why? Because they have a weakened immune systems, which make them more vulnerable, socially vulnerable populations, socio-behavioral populations, lack of access to the proper health care, vulnerable to the development of drug resistance as a result of poor adherence to treatment or suboptimal treatment. So HIV positive TB cases are more likely to be sputum smear negative and therefore less likely to transmit TB. Delayed diagnosis because of the sputum negativeness have led to high death rates, increase in the mortality in the people living with HIV, may also result in a lower rate of TB transmission. Now, MDR TB and HIV challenges are there because diagnosis of TB is more difficult in a HIV positive, smear negative, extrapulmonary. Treatment is challenging because of the drug interactions, intolerance, and non-adherence, and protecting the healthcare workers, especially us, is on the important side. So special risk has to be given and special, precautionary care has to be taken for the HIV MDR TB combo. Now coming to this, major challenges in managing MDR XDR TB in India include all except longer treatment, Drug side effects, drug supply chain, or high effectiveness? What do you think? What is the major challenge? Include all except this is. So please go through the MCQ properly because it has a word of except. It doesn't makes all. Okay, Jason is saying C. Are you sure? Drug supply. Hello is saying D. So it is yes. High effectiveness D. It is not a challenge. Na? If it is a high effectiveness of this, regimen in the MDR cases, why it will be a challenge? The challenge is a long treatment because the patient is not compliant. Side effects of the drug, because of the side effects, the patient defaults the treatment. Drug supply chain, because somewhere the drugs are, sometimes become less available. Now talking about the side effects, and this is again one of the important slides, you can take a note of it because these are the various side effects of each and every drugs. The most important, if we talk about the bedaquiline, the QT prolongation is commonly seen. Hepatotoxicity is also there, arthralgia, nausea. Accordingly, you do a ECG monitoring with the LFT monitoring. Linezolid can cause a myelosuppression, so you need a CBC monitoring along with the, all the complete profile with it. Moxi, levo, QT prolongation, tendinopathy, GI upset. Along, you see ethambutol. So ethambutol induced optic neuritis is very common. So you need to monitor the, stop. Monthly vision check has to be then. Pyrazinamide, hyperuricemia, very commonly also seen in drug-sensitive TB. Hepatotoxicity, common. Ethionomide, GI intolerance. Delaminid, again, along just like the bedaquiline. QT prolongation. Amikacin, kanamycin, although they have been obsolete now, but again, ototoxicity, nephrotoxicity, and PAS, GI upset, hypothyroidism. So accordingly, you do the treatment for this if there is side effect. So if there is a renal impairment, drug which might require an interval adjustment in the presence of mild to moderate renal impairment, ethambutol, quinolones, cycloserine, pass in additional to aminoglycosides. So blood and serum creatinine every month for at least 3 months, and then every 3 months has to be done. Liver impairment, pyrazinamide, pass, ethanoamide are the potentially hepatotoxic. So further management should be on the same guidelines as just like the non-MDR TB. Pyrazinamide should be avoided in liver impairment patients. So if there is a seizure disorder, pyridoxine should be given with cycloserine. Why? To prevent seizures. So among the second line drugs like cycloserine, ethionomide, fluoroquinolones have been associated with seizures, and they should be used with caution. So cycloserine should be avoided in patients with active seizures and those which are being not controlled on the anti-seizures medications. So when seizures presents for the first time during the anti-TB therapy, they are likely to be the result of an adverse effect of one of the anti-TB drugs, and the side effects which we have discussed, you have to monitor accordingly. Psychosis, fluoroquinolones, cycloserine, ethionomide have to be associated. Cycloserine again may cause severe psychosis, depression, leading to suicidal tendencies in the patients. So if the patient on cycloserine develops psychosis, antipsychotic treatment should be started and cycloserine should be temporarily held. Pyridoxine prophylaxis is very important and should be given to prevent the neurological and psychiatric adverse effect. Extrapulmonary MDR TB, treatment regimen and schedule for EP MDR TB case will remain the same as for pulmonary MDR TB. Contacts, if the contact is found to be suffering from pulmonary TB, irrespective of the smear results, he should be identified as the MDR TB suspect. So the patient should be initiated for new or a previously treated case based on their history of previous anti-TB treatment. And simultaneously, you send 2 sputum samples for the culture. BCG prevents severe form of TB in children such as TB meningitis. It would be expected that the BCG would have the same effect to prevent severe forms of TB even if they were exposed to XDR. So the vaccine has shown to be although less effective at preventing the most common strains of TB and in blocking TB in adults. The effect of BCG against the XDR TB would therefore be limited. So newer vaccines are again, trials has been going on, and again I think soon the vaccines for TB will be there in the market. So WHO along with the Stop TB partnership They are actively working on the development of anti-TB vaccines. When we talk about the totally drug-resistant tuberculosis, is a generic term that shows resistance to all the first and second line drugs, has been identified in 3 countries. So we see we are everywhere. So India again leading, Iran and Italy. Center for Disease Control and Prevention termed as the disease untreatable. So if this happens, you have no drug to treat it. What exactly will be the fate you can understand. So TDR TB has resulted from further mutations within the bacterial genome. Beyond those seen in XDR and MDR, development of resistance is associated with poor management. But again, DST occurs in only 9% of the TB cases worldwide. So without testing to determine drug resistance, MDR or XDR TB patients can develop resistance, yes, if you don't do a drug sensitivity testing. So TDR TB is relatively poorly documented, although as many countries do not test patient samples against a broad enough range of drugs to diagnose such as a comprehensive array of resistance. So this was the case in Mumbai of a TDR TB outbreak, and this was the article which was being published in the Times of India, deadlier form of TB that hits India. Prevention, again, rapid diagnosis and treatment of TB. Completion of treatment is important. Patient of HIV/AIDS should be identified, should be diagnosed and treated. Contact should be identified and accordingly treated, and research, much of the research and again more of the funding is needed. Still, I find, and yes, the funding as per if you talk about is comparatively less if we talk about this. So Bill Gates, many more powerful hands are needed to control tuberculosis. So he has donated for this TB program also. So contribute your knowledge, wisdom to prevent spread and control of tuberculosis. So hereby I end my session. And again, open to the any Q&As if there.
Thank you so much, Dr. Ayush, for the session. Actually, if there are any questions from the doctors, we will have a Q&A session. They can write their questions in the chat box and Dr. Ayush will answer them one by one. And one more request, actually, Dr. Ayush. Some of our doctors were like messaging us on our personal WhatsApp groups. They wish to discuss their patient cases with you, Dr. Ayush. So if you're also interested, you can please let us know so we can arrange a digital consultation slot.
Yes, definitely. That would be, because at the ultimate goal is, patient should get benefited. So the more, we'll have a discussion of it, we'll come to know what exactly, we can come up with a new case. We can come up, something kind of very rarely seen. So having something kind of this discussions case related is always welcome.
Yes, sure. And so for that purpose, I will be dropping the helpline number in the chat box. So doctors, if you want to connect with Dr. Ayush for this digital OPD, you can connect with us and we will book a slot with Dr. Ayush and we will also communicate the charges and further we will be sharing the details with you.
So I hope I am clear with all the audience with the treatment, because everything has become isolate to all the participants. I'll tell you, just remember the 3 treatment modalities which we have discussed and all the inclusion and exclusion criteria accordingly. I hope I was clear. Any doubt, you can still ask.
Because there are no doubts from the doctors.
Dr. Satkunam, I tried to cover in a bit slow manner only because if you're saying it is a fast, but I believe that I gave sufficient time with each and every slide if you're finding it, but
no worries, still they will be getting the recording actually.
Yeah, so
we will
you'll
be
be
sharing the
getting, yes,
recording
yes.
with them. No worries. So Dr. Ayush, we will be having further discussion regarding this after the webinar. Thank
Yes,
you
for
so
sure.
much for the insightful session. I hope everyone has enjoyed the session, and on behalf of everyone, I extend our sincere gratitude to you, Dr. Ayush.
Thank you. Thank you so much to all the audience and Team Mediversal for having me here. And Hoping to see you soon, maybe in the next coming webinars. Take care.
Yeah, surely.
Good
Meanwhile,
night.
I have also shared the certification registration form in the chat box. I request everyone, please do fill the form so that you will receive the certificate on your mail ID. Please do fill the form. Thank you. Thank you so much, Dr. Ayush. You can
Yeah.
like
Okay,
drop the
I'm just
call.
leaving the session. Yeah, thank you.
Thank you so much. Bye. And further, you can reach to us. You can follow us on social media platforms. I will be dropping those links as well in the chat box. Thank you so much, everyone. Good night. And yes, special thanks to the candidates who have joined us from Nepal. So, if you people, anyone among you wish to pursue any programs from Mediversal Academy, we have dropped the helpline number in the chat box. So you can reach to us on that number itself. Thank you so much. And I repeat, please do fill the certificate form to get the certificate on your mail ID. Thank you so much. Thank you, Dr. AJ.